Vignesh.
Yeah. A very good afternoon, everyone, distinguished delegates, esteemed chairpersons, faculties, and dear organizers. My topic is drug-induced diabetes, understanding the impact of drugs on the glucose homeostasis. So it's defined as hyperglycemia or new onset of diabetes resulting from the use of specific drugs that meets the definition of diabetes. It is important to distinguish it from the exacerbation of the pre-existing diabetes versus new onset diabetes. And its prevalence is increasing because of polypharmacy and aging populations, which we already discussed, and it should be recognized for the patient safety and optimal management. So we should not cause iatrogenic diabetes. And it's also recognized both by ADA and WHO as a separate etiological category. So drugs like pentamidine, which is used for hemocystatis carinae, and drugs like L-asparaginase used for ALL, and the beta blockers, especially the non-selective beta blockers, thiazide diuretics can cause diabetes by interfering with the insulin production and secretion. And drugs like steroids, which we see commonly, and each drug we are going to discuss individually, and the salbutamol beta agonist and growth hormone and nicotinic acid used as a dyslipidemic agent causes diabetes by reducing insulin sensitivity. And cyclosporins and statins can cause by both the mechanisms, and total parenteral nutrition induces diabetes by independent of insulin mechanism, and insulin checkpoint inhibitors used as a targeted therapy in the cancer chemotherapy can cause even autoimmune kind of type 1 diabetes. So thiazide diuretics mainly cause diabetes by depleting potassium, thereby decreasing the cleavage of proinsulin to insulin, reduces the insulin secretion, and postprandial hyperglycemia and downregulation of peripheral insulin receptors, thereby causing insulin resistance and diabetes. So examples, chlorothiazide, hydrochlorothiazide. One member of the family, the diazoxide, which is a non-thiazide derivative, is even used to control the excess insulin secretion by unresectable insulinomas. So the group has that effect. And clinical PEARLS, it's dose dependent. It's not everyone will be getting this diabetes. It's dose dependent, very rare, 3 to 6 cases per 1,000 patient years when high doses were used. So risk is minimal with lower doses, whose benefits therefore outweighs its risk. So glucose intolerance develops slowly with a mean period of 2 years, and discontinuation of the drug resulted in the restoration of normal glycemia. And the trials, HALA trial, nearly 10% of all patients develop new onset diabetes, and multiple risk factor intervention trial, the onset of new onset diabetes is increased by more than 30% in diuretic treated patients. And next drug is beta blocker, especially the non-selective beta blocker. It impairs the release of insulin from the beta cells and reduce insulin sensitivity as well. Mainly the non-selective like propranolol, timolol, and sotalol, and which we are not using routinely in our practice. So less prominent effect with the cardioselective beta blockers like nebivolol, metoprolol, and with vasodilator properties like carbidelol, it's almost nil. And the risk factors conferred by the non-selective beta blockers is more when combined with the thiazide diuretics, when both the drugs, antihypertensives, are combined together. Several studies have linked the chronic use of beta blockers for long term with an increased risk of development of diabetes. So ERIC's study have also showed that the risk is increased by 28% in patients who are taking a non-selective beta blocker over a period of 6 years as compared to other medications. And statins can cause diabetes in both mechanisms, either by insulin secretion and sensitivity, and some other mechanisms have also been postulated, and especially with the highest doses of rosuvastatin, atorvastatin 80 mg and simvastatin 40 mg, and pitavastatin is not linked to the increased risk of diabetes, so it's safe. So use of statins is associated with a small but significant increase in the new onset of diabetes and slight worsening of the glycemic control in the pre-existing diabetes. So meta-analyses have shown somewhere around 9% of patients have progressed to diabetes, but the benefits outweigh the risk. So the statin use increased the risk of diabetes only by 2 cases per 1,000 patient years treated, but resulted in benefit of 6.5 fewer CV events 1,000 patients. So benefits outweigh the risk. And drugs like fluoroquinolones, the antibiotics, the commonly used gatifloxacin, which was withdrawn from the market, and followed by moxifloxacin, and very least with levofloxacin, ciprofloxacin, because these drugs accumulate in the pancreas and increase the epinephrine levels and prolong secretion of GLP-1 with desensitization of beta cells, the mechanism how it causes diabetes. So initially it will cause hypoglycemia, in the long run it will cause hyperglycemia. So in the short term usage, it can block the ATP sensitive potassium channels and increase the insulin release, thereby causing hypoglycemia, but repeated use can cause hyperglycemia. That's why gatifloxacin was withdrawn from the market, because of this dysglycemic effect. And steroids, this is the commonest thing which can induce diabetes, especially post-COVID. So this causes diabetes by reduced insulin sensitivity, both by skeletal muscle and adipose tissue, and it increases glucagon, thereby it increases the gluconeogenesis and glycogenolysis. The glycogen is converted to glucose, the glucose is increased, and decreased insulin leads to increased lipolysis and protein degradation. Either it can be short acting or intermittent acting or long acting, so what kind of steroids is going to worsen diabetes. And the clinical importance is it can induce a form of iatrogenic Cushing syndrome and probably the most high risk drug causing hyperglycemia. So the incidence is around 30 to 55% in various studies, and individuals with diabetes have rapid deterioration of the glycemic control on initiation of steroids. So we have to educate the patients before initiating steroids and primarily increase the postprandial glucose rather than the fasting. So evening sugars will go up, and we have to check the after lunch values and before dinner values and adjust the doses accordingly, and usually reverses on the withdrawal of the drug if it is short term. So very rare with the inhaled preparations or intra-articular injections of steroids or topical preparations are not prone to cause hyperglycemia. And anabolic steroids like nandrolone is also very safe. And insulin is a drug of choice in most patients with steroid-induced diabetes, and consider transferring evening basal insulin to the morning or increase the bolus insulin by 20% daily dose, so, and beware of the nocturnal hypoglycemia as well, because mostly the fasting can be normal. And next is antipsychotic agents. This is another common presentation in the psychiatric wards. We are able to see more diabetic patients, mainly with the atypical antipsychotics. The typical antipsychotics like alloperidol is very safe, chlorpromazine is safe. And atypical antipsychotics, the mechanism is it is going to working on the serotonin 2A receptor antagonist, thereby impair the tissue glucose uptake is reduced, and thereby causing decreased insulin sensitivity and hyperglycemia. And also it can also act on the serotonin 2C receptor antagonist and impair the leptin action, and thereby causing weight gain. And the disease as such, the schizophrenia or the psychosis for which the drugs have been used, the disease as such can cause weight gain. And the drugs also adding oil to the fire is going to increase the weight gain, thereby leading to hypertriglyceridemia, pancreatic beta cell failure, diabetes, and decay also can be the presentation. So as already told you, the typical drugs like alloperidol is very safe because it's going to cause less weight gain and thereby less anti-diabetic effect. And second generation atypical drugs like clozapine or olanzapine are going to cause more weight gain, so more diabetes. And aripiprazole is relatively safe because of lower risk of weight gain and thereby lower risk of diabetes. Mood stabilizers, the lithium and sodium valproate is going to increase weight gain and cause more diabetes compared to lamotrigine and carbamazepine. And among the antidepressants, the mirtazapine, paroxetine, amitriptyline are at high risk because of more weight gain and diabetes. So the clinical takeaway message is these agents are now known to contribute significantly to obesity, thereby to metabolic syndrome and hyperglycemia. So diabetes is 2 to 3 times as common in people with schizophrenia and psychosis, and blood sugar may return to normal if the medication is stopped. However, if significant weight has been gained over the course of the treatment, insulin resistance and diabetes can be even permanent. So antidepressants may also improve the glycemic control due to amelioration of the depressive symptoms. It can improve the symptoms, and this can confound the results. So use a drug wisely with a low risk of weight gain. And immunosuppressive agents can cause diabetes that can affect the beta cells and proliferation and function. Examples are calcineurin inhibitors like cyclosporin A and tacrolimus, because it reduces the insulin secretion and synthesis, and the diabetogenic effect is more when combined with the steroids. And sirolimus, the diabetogenic effect is more when combined with the cyclosporin and tacrolimus, and this limits the use of these agents in the prevention of type 1 diabetes and explains the high risk of post-transplantation diabetes, around 13% following even solid organ transplantation. So immune checkpoint inhibitors, in the first slide I've discussed this drug can even cause a kind of autoimmune kind of type 1 diabetes. These immune checkpoint inhibitors are a type of targeted therapy used in cancer treatment. The PD-L1 receptors of the cancer cells can attach to the PD-1 receptors of the T cells, thereby escape the destruction by the T cells. The body's own mechanism, it will escape, the cancer cells will escape from the body's destruction, and these drugs are targeted against these receptors. So these agents can cause loss of self-tolerance and lead to various immune-mediated adverse events, including the new onset diabetes. The drugs against PD-1 can be nivolumab, and PD-L1 is avelumab, and it can resemble a kind of autoimmune type 1 diabetes. C-peptide will be very low, and pancreatic antibodies are also detectable in 50% of the patients, and diabetes is irreversible and usually requires lifelong insulin treatment as well. So antiretroviral therapy, they reduce diabetes secretion and increase insulin resistance by interfering with the GLUT2 transport. They also reduce lipodystrophy and lipid abnormalities and induce central fat gain. Among the protease inhibitors, ritonavir and indinavir are at high risk, and nucleoside reverse transcriptase inhibitors, tavudine is at high risk of causing diabetes. So clinical importance, diabetes is 4 times more common in HIV patients treated with highly active hormone antiretroviral therapy. And final slide, take-home message, educate the patients about the classical signs and symptoms of hyperglycemia, early detection and risk factor modification. The risk factors are family history of IGT or family history of diabetes, obesity, metabolic syndrome, older age, genetic predisposition, higher multiple drugs usage, polypharmacy, and concomitant use of multiple drugs. So weakly diabetogenic drugs are antihypertensive agents and statins, and strong diabetogenic drugs are steroids, antipsychotics, and immunosuppressants. With some medications, blood sugar levels may return back to normal once the medication is stopped, but in some cases, the development of diabetes may be permanent and depends on other health factors. If a precipitating drug is stopped, then the diabetes can be easier to manage, and diagnosing IFG and IGT, impaired glucose tolerance, prior to the initiation of the steroids, and monitoring fasting PP and A1C are recommended. Insulin is a drug of choice in most patients with steroid-induced diabetes. In diabetes, it is advisable to use antidepressant, which causes very low risk of weight gain. So start with the lowest thiazide dose and optimize the serum potassium levels, add potassium supplements or potassium sparing diuretics whenever is possible, and maintain the serum potassium below 4 milliequivalents. Thank you.